Ladies and gentlemen, dear colleagues, I am delighted to see so many of you here today. My name is Klemens Kaiser. I come from the University Klinik in Frankfurt, and I am very pleased to be able to share some insights on the Navilas system today as part of the ODOS Masterclass. I probably don't need to tell you much about the University Klinik in Frankfurt. It has been a university hospital since the 1970s, with several specialized departments, including the Department of Retina and Vitreous Surgery. Since the beginning of this year, we have been fortunate to have the Navilas at our disposal, and I am excited to share some of our initial experiences with you. On average, we treat between 10 and 20 eyes per week. This varies greatly, especially due to emergencies. Nowadays, we not only treat vascular occlusions, but can also handle urgent cases of retinal tears. Altogether, we have 6 main users who work with the Navilas regularly. Dr. Bucher and I are the most frequent users. In addition, 2 residents occasionally get the opportunity to use it, as well as a specialist and our senior consultant, Dr. Singh, who also makes extensive use of the Navilas. Our therapeutic spectrum includes not only diabetic retinopathy, but also chorioretinopathy and central serous retinopathy. We also deal with retinal tears, horseshoe tears up to the ora serrata, which can be treated effectively both anteriorly and posteriorly. The microsecond pulse laser is also in use, especially for CSCR. One of the key advantages of the Navilas is the ability to perform contact-free laser treatment. You are all familiar with the challenges of using a contact lens. Many patients barely tolerate it, and it can become very tedious. Some patients even leave with corneal erosions. With the Navilas, about 50 to 70% of our patients can be treated without a contact lens. Of course, in some cases, for example, if patients cannot keep their eye open, a contact lens such as the SuperQuad is still required. Let us move on to a few case examples. The first is a 38-year-old male with sickle cell retinopathy. On fluorescein angiography, we could clearly see areas of complete ischemia and neovascularization with leakage. In such cases, laser coagulation is essential to prevent progression to neovascular membranes and ultimately tractional retinal detachment. With the Navilas, we can take a fundus photo, integrate the angiography directly into the system, and plan treatment precisely. Different areas can be assigned varying spot densities or energy levels, ensuring no areas are missed, even in the periphery. The second case concerns familial exudative vitreoretinopathy, a rare hereditary retinal disease characterized by disturbed angiogenesis. Patients develop peripheral ischemia, neovascularization, and exudation, which can progress to tractional retinal detachment and blindness. As you can see here, the fluorescein angiography shows significant leakage and ischemia. Our senior consultant requested targeted treatment, which we planned and delivered with the Navilas. The result was evenly distributed burns, something that is often inconsistent with conventional lasers, where spacing can be irregular. With navigated laser, every single burn is placed exactly as planned. The previous cases were performed using a contact lens. The following cases were carried out with the contact-free objective. Here, you can also see the caution zones that the system automatically places over the optic disc and the macula to ensure no laser spots are applied in these sensitive areas. The third case is from just 3 days ago, a patient with 2 retinal tears. The entire treatment took 2 minutes. It was easy to plan by marking the affected areas on a fundus photo. For documentation, the treatment can be printed out and given to the patient or referring ophthalmologist, which facilitates follow-up care. With the Navilas, we can reach as far as the ora serrata, often without a contact lens, which is far more comfortable for patients. In this case, we used a spot size of 310 micrometers with spacing between 0 and 0.25 to ensure adequate coverage without gaps. The system also allows for caution zones to protect areas such as the optic disc and macula, or sites of hemorrhage or scarring, where burns must be avoided. This adds an important safety advantage over conventional lasers, where eye movements can result in misplaced burns. Now, let's turn to an example of proliferative diabetic retinopathy. Again, we begin with a fundus photo, which forms the basis for planning. Each green circle represents a planned burn. Areas overlying hemorrhages or vessels can be deselected. Caution zones protect critical regions such as the optic disc and macula. The system then confirms alignment before treatment. The entire procedure is contact-free. The patient only needs to fixate appropriately. For panretinal photocoagulation, in contact-free treatment, we typically use a 440 micron spot size with spacing of 0.75 to 1. We select a pulse duration of 20 to 30 milliseconds. Unlike conventional argon lasers that typically only use longer pulse duration of 100 milliseconds or more, the shorter burns do not enlarge over time, so tighter spacing is required. The burns become visible after a few seconds and can be rechecked after 5 to 10 minutes. Energy can be adjusted on the fly, depending on tissue response. An entire quadrant can be treated in just seconds. Additional burns can then be added if needed. After the session, treatment images are automatically compiled into a report, which can be stored as a PDF or printed or added to the patient's chart. A few practical tips for contactless treatments. It is important that, in order to reach the periphery, the objective lens must still be positioned very close to the eye. This means that with a restless patient, the skin or eyelashes may occasionally come into contact with the lens, causing smudging. The most important point is to always make sure that the lens is thoroughly cleaned beforehand, with no fingerprints or grease marks on it. It is recommended that the pupil always be well dilated simply because it makes the procedure easier. However, treatment can also be performed in cases of insufficient dilation or when the patient has a naturally small pupil. That is a major advantage. But overall, it is much more efficient and faster when the pupil is nicely dilated. We use cotton swabs to gently hold the eyelid open. For many patients, especially younger ones, this is not really necessary, but it can still be more comfortable since when the light is bright, patients tend to close the eye reflexively. We anesthetize both eyes before beginning the treatment. This also helps reduce the blink reflex. Afterwards, we always apply Cornerigal or another highly viscous tear substitute to keep the eye well protected and to ensure that the clarity of view is maintained. Another major advantage with the Navilas is that we can keep the room lights on during treatment. This means we are not sitting in the dark with the patient. If we need something, for example, a cotton swab, we don't have to switch on the light, fetch it, turn the light off again, and sit back down. Everything can be carried out in a well-lit room, which is much more comfortable both for the patient and for you as the treating physician. We will now proceed to a simulated treatment demonstration. The most important aspect when performing laser treatment with the Navilas system remains that the patient is properly instructed. That means we explain the procedure to the patient and clarify what we're doing. It's absolutely essential that the headrest is adjusted appropriately. On the right-hand side, you'll see a marking ring. It should be roughly at eye level. Instruct the patient to place their forehead against the headband and position their chin securely in the chin rest. Then, for example, we ask the patient to look temporally, meaning to the right, so we can access the temporal area. In this case, no visible light comes from the Navilas. It uses infrared light. So even if the pupil is not well dilated and we only want to take a photo, it's still easily possible all the way to the ora serrata. I'll show you that in a moment. Carefully approach the eye. You already see the reflex. And once you have a good image, press the button. A brief flash occurs, and you'll have a beautiful fundus photo extending to the ora serrata. For instance, there were a retinal tear, you could easily target it. Now let me show you a test laser procedure and how it works. You'll notice the pupil isn't widely dilated. The first thing we do is take a fundus photo as the basis for our laser treatment. Then, as mentioned, we set the caution zones. They appear automatically when the laser detects the optic disc and macula, as in this case. If, for example, I say there's an area I absolutely don't want to laser, I simply place another caution zone here or here. Next, I draw the areas I'd like to laser. Let's say I want to laser around the upper vascular arcade. I simply sketch that in. Afterwards, we use the so-called eraser to expose the vessels because we don't want to shoot directly onto them. Or if I say, okay, this area has already been lasered, I can erase it again. Once the plan matches what you envision, you can begin the treatment. We have a standby button here, which activates the laser. Then I approach the eye again. As mentioned, no light comes from the laser yet, so it's not uncomfortable for the patient. Now you'll see the so-called overlay. This means the laser wants to confirm that the area it detects is indeed the one we intend to treat. Once confirmed, the overlay disappears. If you were to load a fluorescein angiography image, that image would also appear. And once we say, okay, we're ready to begin, we press the pedal, and you'll see the laser work through row by row. In this case, nearly 100 laser spots are applied within just a few seconds. If we still see a remaining spot temporarily, we ask the patient to look a bit to the right, and then I can simply add that laser spot, making the treatment complete. In my opinion, the most important thing for forensic purposes and documentation is the report. You'll see a newspaper-like icon in the bottom bar, and when you click it, you get a comprehensive report of the treatment. You'll also see which eye was treated, how many spots were delivered, the values for power, spot size, and total energy applied. Plus, there's a photo from before, during the planning, and after. That's incredibly helpful for the patient, but also for us as practitioners because we know exactly what was lasered and where we lasered. Let me now show you how to manually laser in case of a vitreous hemorrhage. I ask the patient to look to the right. You can, for example, switch to grid mode, adjust the settings again, and once the laser is activated, the grid appears on the display. Using the joystick, you can easily reposition it to where you want the laser to be. Let's assume there's a retinal tear here. I could place the grid accordingly, press the pedal, and all the new laser spots are applied within a second. I'll show you again at this position. A few more laser spots I'd like to apply. I press the pedal and the new laser spots are done. Afterwards, you can take another photo and give it to the patient. That concludes our presentation on the Navilas system. Thank you very much for your attention and interest.